Welcome to the Functional Relations Podcast, where we set aside time to have engaging conversation. I had to swallow halfway through.
Yeah, man. Just take a deep breath before, so you're gonna.
Okay. Welcome to the Functional Relations Podcast, where we set aside time to have engaging conversation on relevant topics related to behavior analysis. I'm Zachary Berg.
And I'm Caleb Davis. Zach, how are you doing?
Yeah, so things are pretty good. I mean, we're kind of living in a weird world right now. You know, we're staying at home, doing our thing. How are things with you?
Things are pretty good. Living the quarantine life currently.
Yeah. You're living quarantine because you got the disease, or?
No, sorry. I'm social distancing right now.
Okay, good.
Yes. Preventing.
Yes, prevention is key. That seems to be the name of the game here.
Yeah, so let's see. It's been going pretty well. Today I ventured out to the grocery store. I wore my mask.
You wore your mask. That's very responsible of you.
Yeah.
I actually knew that because I called you and you answered with your mask on.
Yeah, you caught me in a transition where I was in the process of bringing my groceries in, and I still have my mask on.
And we were video chatting.
Yeah.
And I was a little bit concerned. I didn't know what was going on, but I appreciate that you were being safe. It's good. We need, this podcast would be nothing without a co-host.
That's right.
Just one of us? No, that's not going to work.
Yeah, so I'm doing my part to keep myself and other people safe.
Great.
But yeah, so I think obviously we're in the midst of this COVID-19 pandemic, and the other day we're texting back and forth, and I told you, I was like, you know what? We should do an episode on telehealth. Seems like as I'm on social media and stuff, I'm seeing like everybody is talking about switching to telehealth services. I know something where I live in Massachusetts, ABA providers are getting approval to use telehealth. So it just seems like super relevant topic.
Yeah, so I just looked up the message now, and it's basically just like these kind of crazy back and forth, ha ha ha, and then just kind of like this break, and then you're like, let's get someone on to talk about telehealth soon, ... And I was like, let's do it. And here we are. So we're throwing this together, and I hope it is valuable. We got to find someone who's really experienced, obviously. We need someone who's done research in the area and can kind of talk about, research to practice, right?
Yeah, so we're definitely expediting the shipment on this episode. So we're kind of trying to, like I said, we're kind of throwing it together here. But we wanted to kind of get going on this because it is so relevant right now. And we want to get some information out to people who are, working on telehealth right now. And it might be new to it.
Yeah, that's right. Absolutely. And we're going to offer up a free CE for this one. So no worries about that. People can go on and order it just like they've done always. But it's going to be $0 and 0 cents. So that'll be good.
Yeah, great. All right.
Let's do it.
Hi, Kelly. Welcome to the Functional Relations Podcast. How are you doing today?
I'm good. How are you?
Doing very well. So today, the episode is all about telehealth. So we are in March of 2020. Probably a lot of ABA practitioners are out there, are starting to learn about telehealth and starting to implement telehealth. So we thought today would be a great opportunity to kind of learn a little bit more about telehealth for people that probably could use that right now with their day-to-day work. So would you mind just starting out by telling our listeners what telehealth is, like the definition?
Yeah, sure.
Dr. Kelly Schieltz is an assistant professor in the Stead Family Department of Pediatrics at the University of Iowa's Children's Hospital. She's a licensed psychologist and board-certified behavior analyst.
It's the big umbrella term. So it's been referred to by various terms in the past. So telemedicine, you'll hear telehealth. You'll also hear very specific versions. So you'll hear like in medicine, you'll hear teledermatology or teleradiology or telepsychotherapy. So you'll hear a bunch of terms, but they all fall under that umbrella of telehealth, which is a more commonly used term now. And it's really just a term that defines any medical service delivery that's done virtually. And that can include a variety of different formats. So you've got synchronous telehealth. And so that's a live interaction. So it's happening in real time, just with some video conferencing software, potentially. And then you've got an asynchronous connection, which is going to be something that people will talk about store and forward. And so if we think about in the field of dermatology, they may take an image of your skin and then they're going to send that off to a specialist. And so it's not a live interaction, but then that specialist will review that image and provide then recommendations and suggestions from there. It's really just a tool to just provide that service or various services in a more virtual format. The more common one is probably the synchronous live consultation between people, especially with the way behavior analysts have used it, is definitely more that live interaction. But we also do still use asynchronous interactions where we might be doing more like online modules and training and things like that, where you can access the same information in different ways.
Okay. So I was thinking about this a little bit earlier, and I was thinking, it must be great to be an expert in telehealth now. Like, it's your time to shine.
Yes.
This is it.
Yes.
So how did you get into the area of research in telehealth?
So at Iowa, we've always had the goal of working with parents, and especially parents of really young children. And so when our services were developed, and this is beyond telehealth, but prior to telehealth, we started with these brief outpatient clinics, because most parents, if they've got a concern regarding challenging behavior, they're going to go to their primary care physician. That physician may refer to a specialist, but they're not automatically going to end up in a more intensive setting, right? So we started with outpatient clinics. That then led us to really want to work with parents in their homes. And so then our work and a lot of our projects moved in that direction, where we would directly work with families in their homes. But unfortunately, that was very limited. You can only travel so far in a day, and you can only see so many people in a day. If you're going 100 miles one way, you're probably only going to see maybe one, maybe two at most patients or clients in a day for a 1-hour visit. And so that led us over time to looking into, is there a way we can provide more access that's more time efficient for staff as well as the families? Because even coming into the outpatient clinics, we have families who are traveling one way and it's 4 or 5 hours across the state to get to us. Yeah. So for a 90-minute appointment, that seems really crazy, right?
Right, yeah.
Drive 5 hours back, and you spend a total of 2 hours with a provider. And so that's how we got into telehealth, was really to increase our access to parents of young children and directly in their homes, because that's where they're working with them, right? That's where we see them. So that's how we got there.
Yeah, that makes sense.
Yeah, I definitely see how that could be very helpful for families, especially in rural areas. I know Zach and I, we both grew up in the state of Maine, which is quite a rural state. So I'm just imagining like the community I grew up in and how access to services in general of any type are not readily accessible. So I could see how it could be helpful for communities like that.
Absolutely. And even in Iowa, I think Iowa's a largely rural state. We only have 3 or 4 really big urban areas, and those aren't even that big. But, so there's a lot of states with a lot of rural places, and it's hard to get to the services you need.
Yeah, for sure. I feel like it might be helpful to take a little bit of a step back and kind of talk a little bit about the research that's been done to date on telehealth. Like, one question that pops into my mind is, what sort of skills have been taught using telehealth?
Yeah, so I'll start with our group, and then I'll kind of venture over to a couple of the other groups who've done some telehealth work. So we first started in 2006. Well, that's when the publication came out, 2006. Anjali Barretto and colleagues here at Iowa, they did the first telehealth evaluations in behavior analysis that we're aware of. And so what they did is they actually conducted functional analyses of challenging behavior by telehealth. And so Iowa is unique in that we had a fiber optic cable that ran. It connected all high schools in the state and some community clinics and other service agencies. And so since we were connected with them anyway, we could connect in that way. And so they ran live functional analyses with two kiddos. One was actually, I think, in a Department of Health DHS office, and another was in a school. And so the foster mother ran the evaluation on her end, and the one in the school, the teachers ran it on their end. And so that was the first demonstration of
Wow.
the use of telehealth.
Yeah.
So way back in 2006.
That was before the iPhone came out.
Yes. So
The first iPhone wasn't even a thing.
yeah, so
That's
technology,
crazy.
right? Like, not that great. It's a fiber optic cable. And over time, I mean, we were in that unique position, which was great, but those cables have deteriorated over time. And now with the increase in technology, so then what our group did was, like I said, we were in the homes of families. We were traveling once a week to see them. And so we wanted to stay in the home, but we were really nervous about what decay would occur when we went to telehealth, because you can imagine now we're not in the home, so we can't be there to block problem behavior during an extinction burst. We can't demonstrate anything because now we've got a computer between us. So we then moved telehealth to a clinic-to-clinic model where we stayed in the hospital, and then we connected with Iowa has local child health specialty clinics scattered throughout the state. And so we partnered with them, and we had an assistant, we called them family navigators, who were present in those exam rooms with the families to provide assistance as needed. And then after that, we went back to the home. So the projects we have going on now, we do our functional analyses and functional communication training procedures all by telehealth, but now we connect directly to the home. And so we've got this nice progression. And then because we had done all the in vivo in-home things, the clinic to clinic and the clinic to home, we did an evaluation. This is published by Scott Lindgren, who's actually a neuropsychologist, but he's loved what we've done for years. And so we did a comparison of the three different ways of providing the same service. And we showed no decay in outcomes. And so we continued to achieve 90% reduction in problem behavior across all modalities, which was awesome.
Wow.
And parents' acceptability stayed really high. They really enjoyed that. The only significant differences we found were in the cost. I mean, you can imagine that now we're taking out travel for both the therapist and the family, and that, all of that's gone away. And so the cost, the time efficiency, just the amount of cost it takes to travel, all of that went way down, which was really great.
Yeah. It's a huge advantage.
So our group's done that. And then I should say our group then has also continued to expand that to how do we do that in an outpatient clinical model? Like I said, our outpatient clinics are 90 minutes. And so we've moved that to also doing a functional analysis one day during a 60-minute appointment, and then running FCT sessions across 3 different visits, but those are each 15 minutes only. And we showed really good effects with that as well. So that's in relation to challenging behavior. Other research related to telehealth. So Wayne Fisher and his group has done some really great work with training parents and providers on skill acquisition procedures, all by telehealth. They tend to do a combined model where they have these like online modules that they have people go through first, and then they'll do coaching live, usually with a Confederate child, to teach those procedures and how to do that. And then Wendy Mihalacek's group has done some telehealth work in the schools in training providers on conducting various preference assessments, functional analyses, things like that. So they have also done some really great work in the world of telehealth. So,
yeah, that's cool. So for people who are BCBAs and they're thinking right now because of the virus and their situation they're in, and they're thinking it's hopeless. It's not hopeless. You're saying that people have done a lot of different things over telehealth.
Yes.
So that's awesome.
Yeah. So people have done a lot of different things. We are in a very crazy situation where there's immediate need. And so it can be done for sure.
Yeah, absolutely. I mean, you guys have shown it. So that's awesome. So when I think about assessment, it sounds like you guys have done functional analysis. So that's pretty awesome. What do you guys do for, do you guys do the entire assessment through telehealth? So like that includes observations, the functional analysis, and things like that?
Yes.
Maybe parent interview as well.
How does that work?
Yes. So the version of telehealth that we use, we've never met the families in person. And so it's all been done by telehealth. So we'll start with, usually our first meeting will be just kind of a get to know you type of situation where we'll connect in with them. Well, first we have to make sure they know how to connect in. So we're usually coaching on how do you sometimes start a computer.
Yeah, absolutely.
And so we might sometimes do that by telephone. But once we get connected, we'll do our interviews just through the computer, through the video conferencing software. We'll conduct preference assessments. We usually will start with a series of free plays, just to have everybody get acclimated to hearing instructions through the computer. We also assess like where would the best camera angle be, because for what we do with challenging behavior, we need to see the kid moving around. We're not asking the kid to sit in a chair and never move. And so we have to have open view of much of whatever room we're using. So we'll talk about where does that camera go. Then we'll do those interviews. We'll begin to talk to them about how the coaching is going to work. And so they'll listen to that. And then we run our assessment just like we do in clinic. So we coach as we go. And so if we're running a functional analysis, we're telling them, hey, do this, take that away. Up, he hit himself. Okay, take it away, or up, okay, give him back his toy, those kinds of things. And then we just keep going. And in between sessions, we'll give feedback and more instructions. But we do it all live. There's no prior training. It's just kind of as we go and what we're seeing in the moment.
Oh, that's awesome.
So even though you're doing things remotely, generally you still kind of have the ability to be talking in the moment to whoever's implementing things. So I feel like when I think of telehealth, I'm like, am I still going to be able to do like the things I normally would do? And it sounds like you can. Most
of the time you can. There are some limitations. It's harder to model and show what you want them to do. So sometimes we get creative. If we're trying to demonstrate how to touch a micro switch, sometimes we're often using our hands and we put them up in the camera, like, hey, touch it like this, kind of thing.
Yeah.
But often our vocal language has to be really good, because we don't have the ability to model. So as long as you can describe well what you're doing, that often works. For families where that's difficult to understand, sometimes we'll provide written instructions ahead of time for them to review and become familiar with. And so we will make some modifications as we go. It's also gets sometimes tricky. You can imagine with a screaming child, the instructions we provide maybe
I can imagine that as I'm locked in my house with my 2-year-old. Yes, I can't imagine a screaming child.
Yes. So having parents hear that sometimes can be challenging, right? Because I may be saying, hey, back off, but they can't hear me because they've got their child screaming in their ear. And so sometimes responses, the way we would typically run that functional analysis, may not be as controlled.
Yeah.
And that would be because, we can't control all of that, right? I can't control that mom can actually hear me. And so sometimes we might have to get creative. And is there a signal we need to show them? Do we need to give them a Bluetooth device so that we can speak to them in a different way than just through their computer speakers? But yeah, you can do it. We've not found that anything changes completely from what we're used to doing when we do it in person.
I have a question about observations. When you do observations, are you just setting the camera up or the computer up in the kind of the corner of the room and just staying on the line for a couple hours or whatever? Or are you having people record stuff? Or how do you usually do that?
So we do all synchronous telehealth. Okay. So we've got that live feed going the entire hour that we're connected with them. So when we set up cameras, we tend to find a location in the room that can get as much of the room as possible. Often we will send or have families obtain a wide angle camera so that we can see more of the room than maybe what your internal webcam shows on your laptop. But we've had laptops up on fireplace mantles. We've had them on top of TV entertainment centers. Sometimes we'll put cameras up on tripods and put them in the corners of rooms. Sometimes parents have literally attached the camera up high in the corner of a room somewhere just so that we can get that large angle. So our camera systems, we've tried to go as cheap as possible. So we don't have the ability to control the camera and where it moves. And so if we don't see the child, sometimes we'll have parents go, hey, can you go turn the computer? Can you turn the camera or tilt it down so I can see him laying on the floor? And so we'll often provide coaching in that way too. Hey, I can't see him right now. Can you do X? And most of that's because we're doing research projects. And so to code the child, during that 5-minute session, we need to be able to see them. And so clinically, I might not worry a ton, although I would still want to be able to see them. But
sure,
for research, for sure, we need to see them maybe more often. And so we might just ask them to modify a little bit of how the camera is facing.
If a person had not very good internet, do you folks opt for telephone or any sort of asynchronous stuff, or how does that work?
Yeah, so again, our projects have always been research-based projects. And so if internet was faulty or poor, or they didn't have internet at all, our project, we were in the unique position of being able to purchase that internet for them or upgrade it a little bit for the duration of the project. But even with that, there's always times where the internet's going in and out and videos are fuzzy, and so we sometimes will troubleshoot, okay, turn it off, turn it back on. Rarely have we needed to cancel an appointment just because the internet's not working at all. But because we do everything by visual observation, then we do need to be able to see them. So we don't do things by telephone for the purpose of our projects. There have been times where we have had families record and then send us things. But like we said, most everything we do is a live interaction. And so we don't do that very often, but it's certainly possible. If you've trained a family to run FCT, for example, and you're wanting to check in and see how things are going, there's no reason you can't do an asynchronous interaction where they record it, they send it to you, and then you provide feedback and further coaching from there. So,
yeah, that makes sense.
Yeah, it sounds like the whole process definitely, there's some room for flexibility. So when you say like putting a computer on top of a fireplace mantle or sort of these different options as far as getting observational video, it does seem like there's some flexibility built in. So a clinician, as they're moving towards telehealth, there is some flexibility they could probably have with how that would work depending on the family and things like that.
Yeah, and I think depending on the clinician's needs and what their goals are, you can modify how you set up your telehealth service. And I think those are all great questions to think about when determining how you want to set up your telehealth service and what that's going to look like and what your needs are, what the family's needs are.
Yeah. Obviously, a number of clinicians are moving towards telehealth right at this moment, kind of out of necessity. But if we were having this conversation 3 months ago, what do you think are the big advantages of telehealth? I know you mentioned already it's efficient, right? You can save money as far as travel and things like that. But are there other advantages of telehealth?
Yeah, so I think the biggest advantages we've talked a little bit already, at least for the work we've done using functional analysis and functional communication training for young kids, so 6 and under with autism, we found very little decay in those behavior outcomes, which I think is a huge advantage, right?
Yeah.
So I think that's huge. I think, all the work we do is based in direct observation. So using telehealth, it's possible, right? You can still see everything if you choose to go with a video conferencing format. The other thing too is that when we can connect into the homes of families, we're now in a more natural situation, right? So we can decrease the need for any generalization probes or generalization programming because now we're in the natural environment. I mean, you can even probably do this out in the community. You could take the cell phone and have the kid order food at McDonald's if we were not all under shelter in place. But, but when we're all allowed back out into the community at some point, there's so many ways I think telehealth can be used because it allows us to evaluate what's going on in those naturally occurring situations. So I think that's a huge benefit. And probably the biggest benefit of everything is the access that it gives us. The only thing that probably restricts access at this point is licensure laws. And if you can practice across state lines, if we were allowed to practice across state lines, which some states do have that availability, really then access becomes available to anyone. So if there's not a challenging behavior specialist in, say, Montana, then, well, maybe they could connect with me and I could still provide that service. There's no way I can travel to Montana, but, that would be one option for sure. Or thinking of families in international locations, right? So you think of rural communities in Africa. If they have internet access, there's a potential that we could reach even more families and communities that just don't have any services whatsoever. So I think there's a lot of good reasons to think about at some point incorporating telehealth into your practice if that's a goal for anyone.
It is a goal now.
It is a goal now, yes.
Everybody has set that as goal number one.
Yes, I think it's going to be everybody's goal for sure, whether they had planned on it or not.
Exactly, right. Hey, it's Zach. Sorry to interrupt, but if you're a BCBA or BCABA and interested in getting a CE for listening to this episode, you can purchase it at functionalrelationspodcast.com. This episode is worth one learning CE, but you'll need to provide 2 code words when you go to check out. The first code word for this episode is travel. I like to time travel, mostly back to the 1990s. Travel. 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 If someone were interested or in this case required to use telehealth, how should they get started? I mean, this is one of the parts of this season that we chose the theme research to practice. And we're wondering, do you have any sort of resources or, I know you have a great paper on the guidelines for developing telehealth services. So this is something we're going to put in our show notes. But I was wondering, do you have any resources that we could share with the audience?
Yeah, so I would say there's nothing that's specific to here's a manual that you can use. I mean, certainly we have created a parent manual, but it's not specific to telehealth, really. It's more giving parents information about what our procedures are going to be and that kind of thing. So I think largely it's going to be the research publications that have come out, the book chapters that we have, and I'm happy to share all of those with you. I've probably got them all.
That'd be great.
But using those as a guide, I think the other important resource would really be reaching out to people who have done telehealth work, especially depending on what area of behavior analysis you're focused in. So if you're focused in challenging behavior, functional analyses, FCT, our group at Iowa are great people, and others from our group that have now gone on to their own private practices or other universities that are continuing to use telehealth. They're all really great resources and really great people to reach out to get advice and maybe contract with, to either give some trainings or to provide some ongoing consultation for the beginning, because I think doing this by telehealth, while we can do it, I will say all of us have felt it's not an easy thing to do. And so making sure that you have the competence to do it, I think, is really important. So if you're good at doing this in person, that's great. It's a whole nother skill to do it through a computer and not be able to use your hands and not be able to jump in and show what you're doing. If you're in the middle of an extinction burst, now what do you do? There's so many factors that have to be considered. And so having some people available that have done this and can guide and give some coaching on, what's best, or how to navigate it just to make sure that we're keeping our clients safe, I think is important. And I think many of us would be very happy to consult, and we get requests all the time. And so we're always like, sure, what do you need? Like, we'll send this, we'll talk to you about this. We'll, we're happy to connect in on a couple cases and give you some more mentoring, whether that's in person or it's telementoring. There's ways we can do that just so that we're just making sure everybody is doing what's within their competence level.
Yeah, I think that's a great point. I guess it's like anything else in behavior analysis. If it's not your sort of area, or maybe something you don't really have much experience in, you probably want to be reaching out to people who know something about that and can, like you said, kind of mentor or, give some support kind of as needed. As somebody who's done a lot of telehealth stuff, have you found, Kelly, that there are common problems that beginners or people that are new to it encounter, like common questions that maybe, wouldn't be a surprise if somebody reached out to you, that they're going through?
Yeah, so I think I've probably talked about a few of them. I think one of the big ones is, especially when we're connecting into a home, a problem that comes up a lot is the internet capabilities. An easy fix on that is making sure that people in the household are not streaming and aren't playing video games and using the internet. And so often parents will think, oh, well, I'll keep my other kids busy. I'll give them a tablet or I'll turn on Netflix. But that can really hinder sessions. It can slow down that internet speed. And so we often will have to tell them, you got to get everything turned off, so that we can do this. So I think that's one thing to think about. The technology in general, just, what are those speeds, the video issues. So having some experience or knowledge about how to fix those problems and troubleshoot them. If you have an IT person, even better. But if you don't, often some basic knowledge can go a long way. Turn it off, turn it back on, those kinds of things. Again, I think remembering that your communication is usually only through vocal communication. And so, how good are you at talking with people through a computer screen, and explaining exactly what you need them to do. And also being mindful that there's going to be variations and how detrimental is that to what you need them to do versus not. There's a lot of things we ignore because it really doesn't make a big difference. And then there's things that's like, oh no, I'm going to have to explain that a different way because that does make a big difference. And then there's always disruptions. The doorbell will ring, the dog comes running in, you're trying to restrict tangibles. And then all of a sudden there's, favorite dog pops in, and so, okay, well, that condition is kind of messed up. We're going to have to repeat that. So there's always disruptions that occur or that you're not expecting. And so just being ready for those things to happen and just kind of working through them as best you can.
Yeah, that's great. And I think I'm glad you kind of pointed those things out. In addition to, we talk about like things that could come up from a clinician point of view. Do you have any helpful tips or suggestions on how to prepare families for telehealth? Because, I mean, obviously it could be a change for a clinician switching from in-person to more remote services. What about families?
So I think families largely will be very open to it and are probably actually very used to using technology in some way. I mean, most of us now have cell phones. Most of us have used FaceTime or some other kind of system like that to have those communications. And so they may not be totally out of the loop. There will always be families who have no idea how to turn the computer on. And so we kind of have to navigate through that. But I think it's just being open and honest with them about how this is going to go and what the expectations are. And so if there's a list, almost like a contract of here's what we're going to do. And, here's what I expect from you. Here's maybe how therapy is going to change. So if they're used to in-person therapy, what does that mean when it moves over to telehealth? So does that mean sessions are going to be shorter? Does it mean, what does all that look like? How are they going to hear you? How are they not going to hear you? Just making sure that all of that's clear to them and that they're okay with that and comfortable with it. Most people don't, like I said, are probably not too unfamiliar with some type of video conferencing. So they'll probably be okay with it, but some may not be. And I think also too, one thing with parents, I think you want to make sure though is, because this now does include technology. So what is your policy on video recording it? And then, but also making sure that they're aware that there's always the potential for somebody to connect into what's going on, and that they have to be okay with that. I can't say that that's ever happened, but you never know with those breaches of confidentiality. If some hacker decides to connect into what we're doing, it's always possible that that's now out into the world. And do they consent to that or not? So a couple of things I think to think about. But then I think also a safety plan. So, because again, you're not there. So if the kid gets really aggressive or mom doesn't feel safe, what should that plan be? Do they go to the ER right away? What happens? And so just making sure that there is a plan in place in case something goes awry that you cannot be there to assist with.
So sometimes there are some small things that matter a lot so there are some procedures or whatever that I've run. And it's like, if someone just gave me a little tip, I was like, oh yeah. And it made all the difference in the world. Are there any sort of minor details as it relates to telehealth that, might be overlooked, but are actually quite important?
A couple of things I would think about. So I would slow things down. So I think we get clients that come into an appointment and we're like, go, go, go. Like we know what's going on. We know where things are. At least initially, I would slow it down. So if we're talking challenging behavior, do a good ABC interview, get a good preference assessment in. I think that time that you spend with a family can help gather data you need on how best to communicate with that parent. And so we always set them up where we let the parents talk for a few minutes at the beginning and a few minutes at the end, just to check in, build that rapport. Now, I'm coming from a perspective where we've never met these people in person. And so we don't maybe have that connection already. But I think even if you have that connection, it's still helpful to just check in. Hey, I see snow out your back window, right?
Yeah.
Like, how much did you get yesterday? Having those types of conversations just to make people feel comfortable. You are now connecting into their home. And so just letting them feel okay with that. I think running maybe a couple free plays before you do anything, to see how the kid reacts to you talking on their TV or on their computer. Yeah. You can also imagine kids with autism love computers. And so they often find it very fascinating. Sure. And they want to come talk to you and they want to play on it and they want to do all those things. And so making sure that we're not continuing to get that reactivity to now this, we call it a big talking head. it's kind of, for some kids, it freaks them out that now all of a sudden there's this big person talking to them or talking to their mom. And so we often will run several free plays before we can get that behavior down to a low level where it shouldn't be occurring. And if it doesn't, then we might think of moving to like a Bluetooth headset where we'll use cell phones and things like that to then coach and give mom that, and we can turn off our cameras and do things like that. So just making sure that reactivity has gone away and how you respond to that. I think other things is lighting. So you kind of have to be careful of where computers are placed and where you as the provider are placed, because depending on how the sunlight is coming in the windows can make the screen really dark and then you can't see anything, and then also making sure you're thinking about privacy. So, having headsets with microphones on the provider side can be really important if you're in a room with multiple providers. You don't want that interference from other people who are also doing telehealth sessions at the same time. You don't want families to be able to hear each other, and you also don't want to disrupt providers. And so either having individual offices, if that's a possibility, where doors can be closed and you can use that kind of equipment just to make sure that you're keeping those things as confidential as possible. Those would be a few things I would think about that maybe you wouldn't think about going into it.
Yeah, that's right.
Yeah, that actually seems super helpful. Those are the things you just mentioned. I hadn't thought about at all.
Neither did I.
Yeah, definitely seem helpful.
We didn't think about the reactivity one with kids with autism. We thought, we're just gonna run our FA, and then we got in there. And we're like, they're really scared of us. I mean, some of them were just really scared, and we're like, we're gonna need to fix this.
Yeah, that's a good point. That is good.
Something I was actually wondering about as you're talking about that is, are clients ever distracted by the computer in the sense that they want to use it, and there's this computer in the room that maybe they're trying to they're kind of gravitating towards? I don't know. Has that ever happened?
We're talking kids with autism. It comes up all the time.
Yeah, that's the tangible item they actually use in the FA.
Yes. So that happens a lot. There's a couple things we've done. So sometimes we'll have multiple devices available. So whatever devices we're using for the video conferencing, maybe the family has a separate tablet that the kiddo can use. So we've done that. We've had equipment that we could lend them. So sometimes we would send an extra one that they could have. Sometimes we've recommended, hey, why don't you give them access to that thing an hour before, and hopefully get some satiation going on that they're not going to want it as much. If they're really interested in the person, the provider who's talking, sometimes we've set it up and we've trained up the behavior where I'll talk to you, at the very beginning and then at the very end. And then we put all the other behaviors on extinction during the session. I think sometimes that's provider preference. I actually, when I would run sessions, rarely ever talk to the child at all. And so they usually just were never all that interested in me. But I have other friends, colleagues who are really entertaining. and they can't help but, be engaged with the kiddo. And so they would just train it up where, okay, now I've got to talk with mom. And then I think sometimes what they would do is turn off their camera so that on the family side, the family can't see, or the child can't see us. And so it looks like the provider has disappeared, even though we're still monitoring everything on their end. And so
it's smart.
There's different workarounds we've done because that technology, it is a big motivator for a lot of those kids. And so sometimes you got to be creative.
For sure.
Great. This conversation has been super helpful. I know personally I've learned a lot about telehealth, and I'm sure Zach has too. Kelly, is there anything else you feel like is important for people to think about or know about when it comes to telehealth that we haven't already talked about today?
I do think provider competence is a big thing to consider. I guess another thing to consider are the clients you do serve by telehealth. And actually, this maybe is a good point to bring up. So, at least for challenging behavior, the research we have is that FA-FCT works really well for kids 6 and under with those developmental disabilities. We don't really know the limits of telehealth at this point. And so I would be hesitant to do some telehealth with a really aggressive kiddo that I can't keep safe or that I can't keep mom safe. We also have only worked with kids that have social functions. And so kids with automatic functions, we don't really know how telehealth will or will not work out. And so I think it's considering what those limits are and just being prepared for that. So, or even procedural fidelity. If parents can't maintain procedural fidelity, is it worth continuing telehealth or not? We've had families where we've been like, this can no longer happen. We need you to come into clinic because maybe we do need to model what's happening. Or if we don't think we can keep them safe, then we'll say, okay, no, we need you to come into clinic. We've got to suspend this for now, maybe get things under better control, and then we can maybe revisit that. But I don't think we can walk into telehealth globally and say, we can do this for everybody. I think we still need to figure out what the pros and cons are and where those lie. And I think, especially these days with everybody having that necessity to do telehealth, I think it's really imperative that we all continue to take data and then disseminate that data to our field so that we do better understand what those limits of the service modality are, because I think that will inform our practice moving forward. So I think that's really important for people to think about before just jumping in and saying, yep, we do telehealth now. But how do you keep everybody safe, and what's going to be worth it? What's going to work for you? What's going to work for them while maintaining the integrity of what we do?
So if you're a BCBA, you are a BCBA, if you were a BCBA and you're kind of in this situation where now all of your clients are telehealth, like last week they weren't, and this week they are. Do you have any advice or things that people could think about?
I think one, give yourself some grace and leeway.
That's good advice.
I think this is a tough situation to be in, and we didn't get in this field because we want to make money. We got in this field because we want to help people and we want to help families and help children. And so I think people that are diving into telehealth now are doing it because they want to help and they don't want to abandon those families. And I think that's really admirable. But give yourself some grace because it's going to be hard and we're all stressed and it's not going to be perfect. There's probably going to be more pitfalls than there are successes at this point because one, they may not have the competence to carry it out successfully on day one. But I would say reach out to people who've done it and get some feedback and consultation on that, just so that you feel a little bit more comfortable doing those things. And you'll learn it over time. We'll get there. And I think everybody's heart's probably in the right place. And so I would take that, but be patient and reach out because that's where we are, right? And
that's right.
We've got to get there.
Yeah. Well, thank you. Thank you for coming on the podcast. I think you had some great advice, and I hope that sometime maybe you can come back again. This was great.
Yeah, I would love that. Thank you.
Thanks so much.
Thank you.
Hey, yeah, welcome back. This is the time in the episode that we've decided to set aside time to show our appreciation for all of the people who've come around and supported us.
Yeah, we've received support in so many ways. So we just wanted to take a moment to say thank you. So thank you.
That's right. Yeah, we actually got a really nice iTunes review or Apple Podcasts. I actually don't know the difference, to be honest, Caleb. I don't use Apple products and I don't know the difference, but I think you can find it in both places. Apple Podcasts is the app, iTunes is like on your computer, I guess. But anyway, we got a really nice review the other day, and it really made my day. That's why I sent it along to you. I hope it made yours. It was great. That's right.
Yeah, it was really nice. So definitely feel free to keep those coming. We do appreciate those.
Yeah. We also appreciate comments on our Facebook or Instagram posts. Or if you wanted to send us an email, you can do that. It's functionalrelationspodcast@gmail.com.
Yeah, and something I definitely want to point out is our Patreon supporters. We really appreciate their support. That means a lot to us. And if you're interested in supporting us on Patreon, that's always an option. So feel free to check that out.
Yeah, Patreon is a website that allows creators. There's some photographers. There are some people who do videography. They offer things like behind-the-scenes posts, bloopers, providing updates along the way. And we also send along a few small gifts to our members to show our appreciation. We actually have a magnet going out to everyone this week. So hopefully they'll receive that. You can learn more about becoming a Patreon member at patreon.com/functionalrelationspodcast. We'll also leave a link in the show notes if anyone was interested.
Thanks again to everyone that supports us. All right. So let's discuss the interview that we just had with Kelly Schieltz.
Yeah. After meeting with her, I was just like, I felt optimistic. Did you feel that way?
Yeah, kind of. I mean, I think that obviously when you're talking to somebody who has experience doing something, I think it seems far less scary, right?
Yeah, right. It's like, I've done this before.
So even though you and I are like, telehealth, like, oh my gosh, like we're all of a sudden have to do this thing. She's like, it was almost like her experience was calming in the sense that it's like, yeah, telehealth, we first published in 2006.
Right. Before the iPhone, we were doing this. So why don't you guys relax?
Yeah. I'm like, what was I doing in 2006? Like a lot of time has passed that people have been doing work in telehealth. So this is not new news. In some ways, this is over a decade old news.
Yeah. So. I was graduating high school. So there you go.
Fun fact.
Oh, we met in the year 2006. Caleb. That's
Oh,
neat.
wow. Oh, yeah, that's cool. You and I have been friends ever since telehealth came out.
You know, I thought it was really encouraging. They're doing FAs, right? They did FAs over telehealth, and it seemed like their bread and butter was FAs with functional communication training. And, you know, I kind of feel like if you can do FAs over telehealth, then you can basically do anything, right?
Maybe not anything, but probably most of the stuff that we tend to provide as part of a behavioral service package, I think so. But yeah, I agree. I think like the idea that they would run the entire assessment process without ever meeting somebody face to face, I think that's pretty encouraging. So like they would do interviews, that the FA, observations, all of that remotely. And Kelly was saying that like other research groups have also done things like teaching people to do skills assessments, also like preference assessments. So I think like a lot of our procedures that have been implemented in a face-to-face way, it seems like there's reason to think we could also do it remotely.
Yeah, and I think that because many of us are switching from direct care to telehealth, we've already built rapport with many of our clients, and that gives us an advantage over, so they were doing it telehealth from the beginning to the end. We have the luxury, at least many of us have the luxury, that we are already familiar with our families, and all we have to do is make this adjustment to telehealth. And I think that gives us an advantage. I am starting a few cases just from the get-go with telehealth. So, it's a little bit more challenging, but I'm more confident now after knowing that there's been research in every aspect of what needs to be done to accomplish the assessment. So,
yeah, there were a couple things that kind of stood out to me that, there seemed like helpful considerations when you're knowing you're going to provide telehealth services. One was that, even though you can do a lot of what you would typically do if you're providing in-person services, the piece that you might miss is you're not able to necessarily model certain skills working directly with the client. So it seems like you really have to step up your game as far as your verbal repertoire of being able to instruct people very clearly what to do and kind of like coaching. So something that stuck out to me that probably important.
Yeah. I think in some sense, you could bring this back to our whole discussion on fall through ABA and escape extinction. And, in some sense, it's like, all right, well, if we've been practicing those type of things, using positive reinforcement and not needing as much hands-on stuff, then maybe this is not too bad. Like, we can kind of coach people verbally through the things. It's a skill we have to develop. It's not going to happen overnight. But, we have to make adjustments. I think there are adjustments for both parents and for the kids, right? Seems like that.
Right. So for parents, might be helpful to provide some assistance with technology, like maybe providing them with things like written instructions or stuff, like a task analysis of how to access the telehealth service.
Right. I like the idea that she mentioned where you could potentially call them on the phone because they're familiar with phone calls and kind of walk them through helping them get logged in. And then, once you're logged in and you got the video chat going, you can just end the phone call. But I think that could be a nice reassurance for people. I know that my work so far, it's been, some people are like, I don't know if I can do this. And I just, I'm just focusing on like, it's a big adjustment for everyone. But, the first time you log in is the hardest. And after that, it's easy because you've done it before. And, we just have to know that there's going to be some adjustments. And I think she said it'd be best if we can just slow things down. Like, we don't have to be in a rush to get everything done in the very first session, like, and expect it to go normally. Like, let's just slow down, get people connected, make them feel comfortable, and then we can go from there.
Yeah, I think one way you might think about it is like it's kind of introducing this whole other set of variables into our already complex practice oftentimes, right? So you have like, when you think of like parents, we're now introducing like this variable technology. And so, we might have some parents that are, know even more about technology than we do, versus we might have other parents that, like we're talking about, might need really clear kind of explicit instructions on how to get up and running. And I think the same with clients.
Yeah, they're used to you coming to their house and, saying hi and shaking their hand and saying, how are things going? And like, maybe they're used to you playing with them or whatever. And then now that you're just like on their computer screen or on their iPad, and that's just weird. And so it probably takes them an adjustment just like everyone else. So I think the idea of like doing some free plays at the beginning, just like letting kind of the reactivity subside, is a good practice.
Yeah. So another thing that came out of the conversation that I think is really important to talk about is the ethical considerations that come along with sort of this transition to telehealth.
Yeah, that's right.
Like anything in behavior analysis, if you don't have a lot of experience with it, it's important to gather resources and reach out to people who are familiar with it that can give you some guidance or mentorship, right? So I think that telehealth is no different.
Yeah, it seemed a really important point about competence because, we're new to this. We're getting through. We're trying to do it the best we can. But there is an ethical dilemma in a sense, which is that, yes, we have to do our jobs, provide our services, do the best we can, but many of us don't really know all that much about providing telehealth services. And it's a skill, it's actually a set of skills that has to be developed.
Hey everyone, it's Caleb. Sorry to interrupt, but if you've been listening to this whole episode and you're interested in getting a learning CE, the second and final code word is box. B-O-X. Box. Like Forrest Gump said, life is like a box of chocolates. Box. When you finish the episode, head on over to functionalrelationspodcast.com to purchase your learning CE. And remember, if you're in need of ethics CEs, you can get 2 ethics CEs for any of our episodes from season 1. So be sure to check those out.
So I think it is an ethical consideration. We should try to get information when we can and try to, study up.
Yeah, I agree. And a point that Kelly made at the end, which I think is a really excellent one, especially during this time, is that we should all just give ourselves some grace during this time, because
right. That was great too.
Yeah, I think that we all are trying to do the right thing. We want what's best for our clients. We want what's best for our client's family. And I think everybody out there in the ABA community is just trying to figure out, like, how do we continue to provide these services that we know people need so much? And if you're not that familiar with telehealth, it's probably going to be an adjustment. It's probably not going to be perfect right off the bat, because it's like anything, it takes a little bit of time. But I think that's okay. And I think that, kind of giving ourselves permission to have that grace period is an important point.
Yeah, I think that 2 pieces of advice and 1 piece of inspiration. Let's slow things down. We don't need to go at breakneck speed like we usually are going. And 2, give ourselves some grace. Kelly made both of those points, and I think that they were great to summarize what we should be doing. And then the point of inspiration that I just took out of this whole episode was, like, we can be optimistic. There's a lot of things going in the right direction for us. I mean, the ABA community has been really coming together. Haven't you noticed that?
Yeah, I've seen so many things online that people and organizations have been posting as resources related to telehealth. I think knowing that, there's a shift in, like, the type of services across a lot of the country right now, people are kind of stepping up to the plate as far as being able to offer resources and help everybody and help the field kind of, like, gain that confidence that we're just talking about. So I think that's really good how people are coming together and being supportive sort of across the field right now.
Yeah. And, to be honest, we rushed this episode out because we are just trying to do our part. It's a very, very, very small part, but, we offer it up to the people who are listening, and we're offering this episode for CEs, and they're going to be free. Anyway, I thought that was a really good episode, Caleb. What do you think?
Yeah, I thought it was a really good episode, and I certainly learned a lot, and I hope our listeners learned a lot as well and found it valuable during this time, and hopefully you could take away some things that Kelly said and apply it to, what you're doing right now if you're currently working in telehealth.
Oh, one more thing to mention, Caleb. The University of Iowa, where Dr. Schieltz works, is restarting their school psychology program this fall in 2020.
Yeah.
Yeah, and then the BCBA program, they're going to start it up next fall, 2021. So that would be pretty neat.
Oh, yeah, that's cool.
Yeah, they do have opportunities at the University of Iowa's Stead Families Children's Hospital in pediatrics. They have clinical and research opportunities for students who are working on their master's or PhD in behavior analysis. So yeah, if you're a student, that'd be really interesting. You should go check it out. If you want to get one learning CE from this episode, it'll be available for free on our website at functionalrelationspodcast.com. If you want to support our podcast, you can go to patreon.com/functionalrelationspodcast. And thank you, Caleb. This was a great episode. We'll be back again May 1st with another episode. Thank you, Caleb. I thought that was great.
Thank you, Zach. Talk to you soon.
All right. See you later. Bye-bye.